So at this point, I want to introduce Mackwellings Phiri. He is a social scientist based at Malawi-Liverpool-Wellcome Trust. Since 2009, he's conducted social science research on a range of ethical issues like data sharing, community engagement, and also in health, HIV, TB, influenza, COVID-19, on those topics. So he's currently studying for his master's in global health at the Liverpool School of Tropical Medicine. He has, through his research career and current studies, developed a particular interest in bioethics and climate change. He's also currently part of a team implementing a public engagement initiative on antimicrobial resistance. So over to you, Mac.
Thank you very much, Aaron, for the kind introduction. So briefly, I'm Mackwellings Phiri, based in Malawi. And thank you very much to Global Health Network for inviting us to present a project that we're calling Responsive Dialogues, where we're engaging the public to develop and pilot strategies for delivering policies and action on antimicrobial resistance. This project is funded by the public engagement team at Wellcome Trust. So just to give you a quick overview of AMR and the context, Malawian context. So as you may already be aware, antibiotics are one of the most commonly used groups of medicines, and they form the foundation of most contemporary medical and healthcare practices. The graph showing on the slide is from Patrick Msisha's work that found that there's been a rapid increase in bloodstream infections that are resistant to first and second line antibiotics in Queen Elizabeth Central Hospital in Blantyre, demonstrating the urgent need for action on AMR. So our Responsive Dialogues project is building on and extending existing partnerships between the Antimicrobial Resistance Unit at the Ministry of Health and is also drawing on the Malawi-Liverpool-Wellcome Trust expertise in social research, AMR, and public engagement. So the previous speakers talked about responsive dialogues, and I'll just be repeating some of the things that they already said, but responsive dialogues are about facilitating dialogue, learning, solutions, and the idea is to enable change in attitudes, behaviors, and policies and practices on antimicrobials. And through this process, stakeholders are able to jointly examine and unpack evidence, data, and messages that are provided by researchers and experts and come up with solutions to address critical health issues. So the responsive dialogue tool, as you may have already heard, uses participatory approaches to bring together affected communities and key stakeholders with the aim of sharing information to galvanize action and create local solutions to reduce the burden of AMR, and it takes the One Health approach. And the aim really is to ensure longer-term engagement and also to empower communities to come together and facilitate inclusive policymaking, taking into account public perceptions and local realities. This tool was developed by the Wellcome Trust, and the idea was to help facilitate responsive dialogues on drug-resistant infections. And we, just as the talent team, we've been invited to pilot this approach, and we are assessing the feasibility of the approach. So just to give an idea of how we're implementing this project, the project began in October 2020. We're implementing the program in 3 stages, with evaluation of impact being undertaken through a qualitative inquiry where we're conducting interviews with a subset of participants. We're also evaluating the process through using field notes and the reflective meetings that we are having every time we've conducted the responsive dialogues. We will also conduct interviews 6 months after the conversation events in order to understand the impact. So Before we started implementing the responsive dialogues, we held a stakeholder workshop where we invited stakeholders and policymakers from across the One Health spectrum. And during the meeting, we identified the key goals of the project, applied to groups to work with, and the key ways to communicate AMR. So throughout the process of conducting responsive dialogues, we've been working with a visual artist, Kasim Mundoka, and the idea has been to capture key messages and develop images that are relevant to the context. We're also working with a linguist at the Malawi-Liverpool-Wellcome Trust to help us translate these messages into Chichewa, with the aim is for the AMR program at the Ministry of Health to have visual images that they can use to communicate AMR. So just to give an idea of the groups of people that we've been engaging so far. So we targeted specific groups, and the reason being we wanted to reflect lived realities of the people. So far we've been working with 3 participants groups, and these are animal and poultry farmers, community prescribers, or dispensers of antibiotics, so people who are pharmacists or drugstore owners, as well as AMR community members. So for each group, we held 3 conversation events using participatory approaches to facilitate the exchange of information with experts and participants. The conversations events centered on raising awareness of antimicrobial resistance and exploring the drivers and identifying solutions from participants' perspectives. So here I just want to share with you what we've been learning through this process of implementing responsive dialogue. There's a lot that we are learning from this process, but I thought I would just highlight a few from these. So what we're learning is that responsive dialogue can be very effective at sharing complex scientific concepts such as AMR in a way that allows for discussion and reflection from all participants, including the experts. We've found that it has allowed for an inclusive and accessible approach to discussing behaviors and practices regarding antibiotic use and ways to communicate better practices. We've always aimed to include the wider systems and structures as well as individual behaviors when framing the problem and solutions. So for example, this included participants reflecting on how community members may face competing priorities, and accessing antibiotics out of the health system was easier for them. So for another example, for example, is community prescribers felt they should be giving antibiotics only to patients with a prescription as one of the solutions, but they were also worried about losing customers and killing their business. So this was when we were discussing solutions. And then they were also able to reflect on what could be some of the side effects of the solution that they were proposing. And in the case of the farmers, the most generally proposed stopping giving antibiotics to animals, but they were worried about low production and not being able to meet their daily economic needs, because by stopping giving antibiotics to the chickens, then production was going to be low, which was going to affect their business. But they were also worried that if they stop giving antibiotics to the chickens, which is going to affect production, then this was sort of leaving the market to large poultry companies, which are already dominating the market. And then they had these concerns that if we're targeting them, we're kind of just killing their business and then allowing these large poultry companies to flourish. And in relation to communicating AMR, so in Malawi, there are no words for antibiotics in the local languages, which means AMR messaging can be challenging. However, through working with linguists, artists, and people from the media, we are able to identify effective ways to communicate AMR. One of the greatest challenges we've encountered is managing the complex power dynamics that exist between the experts and the participants. So we've worked hard to manage these power dynamics through briefings and creating inclusive spaces. So before holding a conversation events, we would invite the experts over and then brief them on how to maybe engage with people who are maybe perceived to have less power, and then brief us why we're engaging them and how maybe to interact with community members. However, we've not always managed to overcome these challenges, because sometimes even though we tried to do that, we took this approach, but we still encountered challenges related to power. We've seen through these public dialogues that historical involvement of communities in research can limit communities to take ownership of the health interventions that they are developed with their support. And we are aiming to overcome this through these dialogues. So one thing that we've seen constantly through these conversation events is that initially we've explained to the participants that we're giving you a space where you're able to discuss what you think are the problems or what you think is contributing to AMR in Malawi, but they've always been saying or perceiving us to be trainers, people providing training. So, and then when they develop these solutions, they don't think they're the ones developing these solutions. They still see us as the ones telling them what to do, even when we've given everything to them, saying, you discuss what you think is a problem and how you think you can tackle this problem. But if you listen, you go back to them and ask them how to think about the solution. Or think about the process. They're saying, thank you very much for teaching us ABC, we didn't know about this. So it goes back to how the communities have historically been engaged in research. Researchers have always been coming in to sort of give ideas to people, telling people what to do and telling them how to solve their problem. So I think this has reflected several times in these responsive dialogues. I think that's all I prepared to share with you. Thank you very much for listening.